So why do you think psychopharmacology is important when you look at psychiatric mental health nursing? As opposed to, why does it play a really key role, even comparing it to med-surg nursing? Why do you guys think it's really important?
We need to manage, but also we have to be aware of the side effects. Certain side effects when you take some meds.
Yeah, they have serious side effects. And also when you look at psychiatric mental health nursing, there's not a lot of medical skills that you actually utilize in psychiatric mental health nursing. A lot of it's very med-focused. You're controlling a lot of these signs and symptoms with medication. So a really in-depth knowledge of psychopharmacology is really important. So before the middle of the century, it was actually a lot of amphetamine-based, sedative-based medications were utilized. After that, we started getting into the realm of antipsychotics, antidepressants, and the anti-anxiety medications. So when you talk about your psychotropic drugs being used as an adjunct to different types of therapy, individual and group therapy, what do they mean by saying that it's supposed to be used as an adjunct therapy to your drugs? Yeah, it's being used in combination with. And so the big thing is your drugs can't solve all problems in your psychiatric setting. You really have to take a multi-pronged approach whenever you look at treatment in a psychiatric setting. But why do you think that it's really difficult in your psychiatric mental health setting to treat patients with medications and therapy? Yeah, compliance is a huge issue. That's the big thing. Because you're dealing with difficult patients. You know, you've just done your med-surg rotations, and you think about how difficult it is to get patients that are quote-unquote compliant to do things that you ask them to do, dealing with families and all of those types of things. To get a patient that's, well, crazy to follow the rules, that's really hard. So looking at the ethical and legal implications of dealing with patients in a psychiatric setting, so you have to be aware of what your patients has the right to do. And so you look at what states and commonwealths enforce. And so in the psychiatric setting, does a patient have the right to refuse treatment? And they still refuse treatment even if they're being hospitalized for a psychiatric issue. Yes, they can. So I see a lot of people shaking their heads. And yes, they can. If they're stable and if they're able to comprehend what's going on. However, in emergency situations, the nurse can intervene and the doctor can order medications to treat issues. If they're what? What's the big caveat here?
Danger themselves or others.
I'm sorry?
Danger to themselves or others.
Yeah, if they're a danger to themselves or others. And so that's when the nurse or doctor can intervene. The nurse obviously following the doctor's orders. Can intervene to keep the patient or other people safe. So if they're highly aggressive, they're saying that they're going to harm themselves, have suicidal ideation, that's when they can intervene. Now, what method do we want to always start with first? Talking to them or utilizing the least restrictive method first, and then we move up to the most restrictive. So what would be considered the most restrictive type of option in the psychiatric setting? Yeah, you're looking at seclusion, restraints, forcibly giving medications. Your least restrictive options are obviously trying to talk the patient down, having open dialogue with the patient, having the patient accepting to take IM injections without having to put hands on them. And a lot of times if you have a good rapport with the patient, or even a tech has a good rapport with the patient, then you can develop good enough dialogue with them to be able to get them to do those types of things. So when you look at the assessment in terms of the role of the nurse with your psychiatric patients, why is it important to do a good, thorough assessment with your patients in a psychiatric setting? Yeah, so you can know if there's any types of changes that are happening, and you need to have a good baseline assessment and know where the patient's coming from, because a lot of times they can have incomplete histories. You might not know everything that they're on. They can be really unreliable historians. And so you have a lot of data that you have to sift through and that you have to kind of put the puzzle pieces together because that physician's relying on what your picture is of the patient, what you're painting for them, to be able to appropriately prescribe medications and develop a treatment plan for that patient. Again, because a lot of these medications, like you guys stated earlier, have a lot of serious side effects in very narrow therapeutic ranges. And so we have to be aware of what we can give these patients. And as we get further into the lecture, a lot of things decrease or increase the effectiveness of these medications and the efficacy of them. So we want to make sure that we're giving the proper doses. Okay, it's like, oh my God, it's 2:05 again. I thought I never was going to have to deal with this. But what do we want to do when we're looking at the administration and evaluation of our medications? So what do you always want to make sure that you're aware of before you give any type of medication? How do you properly do it?
Right, physician write those, right?
Yeah, you want to be aware of the rights. You want to make sure that you're being very proper in the implementation of giving the medication and administering it safely and effectively. And this is really key when you're dealing with your psychiatric population because you're going to have two types of patient. The patient that will take everything that you give them and anything and want to take more, they'll pick up crap off the floor and eat it. And then you'll have the other one that is paranoid and doesn't want to take anything from you. And so you've got to over-educate them and try and convince them to take medication. So you've got the two spectrums of what you're going to have to deal with in a psychiatric setting. So you have to be very aware of what you're giving a patient. Like Central State, for example, they put all the medications in plastic bags still in their package because they have so much paranoia in the hospital. Patients don't want you even touching anything that you give them. So they just figured out it's easier to put everything in a sealed plastic bag still in their packaging, and then you open it in front of them, out of a sealed bag, and you can see everything you're doing. It works really well. And so you want to monitor that patient for any side effects and adverse reactions, because that's definitely in our scope. And so, just off the top of your head, even before we get into the explanation of the classes, with a lot of these medications, like your benzodiazepines, your antipsychotics, what's going to be a common thing that you're going to be looking for if you overdose a patient?
Respiratory.
Yeah, respiration, sedative effects, and so you're going to want to be monitoring that. We'll get into talking about EPS, so your extrapyramidal symptoms. You're going to want to be monitoring for any tardive dyskinesia, Parkinson-like symptoms. And then you're going to have to act quickly because these things can get worsened really fast. Another big problem and something that's difficult and where you'll develop really good communication skills as a psychiatric mental health nurse is communication. So what do you think some of the barriers are to communication when you're in a psychiatric setting? What's more difficult and challenging about the psychiatric setting versus the med-surg setting or other specialty settings? Like OB's great because everyone's so freaking happy. There's like a new life in the world. No, yeah, tell me everything. No one's happy about schizophrenia. Like, they don't want to talk to you about that. So, your son has schizophrenia. It's a happy moment. Everyone wants to throw crap at you. No one wants to talk about it. But so, what do you think is difficult about client education with these patients? Embarrassment. And then also just being very apprehensive, very paranoid, and then also their histories. There's staff shortage everywhere. So I might be the only nurse with huge 6'3" white guy that's completely homophobic, hates gay guys. Well, dude, I'm the only nurse on the unit. I'm all you've got. Who's doing your assessment? It's me, I'm here for 12 hours. You got no one else to talk to. We just gotta work with what we've got. So, sorry if you wanna punch me and kill me. We gotta make it a good assessment. It's gonna take a long time. So, brace yourself. And that's happened. And I'm like, we just gotta come to a common ground that you don't like me, and I don't necessarily like you either. You smell horrible. But you gotta make it through this assessment one way or another. So the quicker you answer my questions, we will get through it. So you just gotta make do with it. You got it. So it's very difficult to communicate with these patients and break down certain barriers. And so you try and develop a good rapport with the patient. And you kind of evaluate their personalities and what you can feed off of, and get the patient to cooperate and listen to you. And so you want to explain medications very thoroughly, why they're taking them, how it affects them. And if they're completely against taking a certain medication, you need to listen to them. You know, I've had patients tell me they're allergic to medications, or medications don't work, and some of them have actually been right. You know, that they've tried these medication regimens in the past, and they have been telling the truth, and so you can switch them to a different antipsychotic or something like that, and it will work. So, just a brief overview of how antidepressants, antipsychotics, those types of things work in general. Kind of a homage back to your AMP days, but I'm not going to test you super hard on any of this. You might get one question or something. It'll be very general, so don't freak out. But the core concepts of how these things work. So you've got your neurotransmitters and your receptors. So your neurotransmitters consist of chemicals that are stored basically in the brain. Like, don't freak out about, axon terminals and presynaptic neurons. So you've got your chemicals that are stored in the brain, and then they're also comprised of the electrical impulses. If you remember your pictures of the brain, so you've got these synapses that move faster and faster, and electrical impulses go through the brain. And then you've got your receptors, and all those lovely antidepressant commercials where they've got like the mushroom popping out, like a little skinny, and then you've got the bubbles go back and forth, and it makes it all look really simple. Well, that's what they bind to the receptors, and they keep things from being taken to the brain, and all those chemicals stay free, and then they make you feel better. And so when you've got these free-floating chemicals in the brain, the reuptake of these chemicals, again, help you feel better, and that's what's comprised of these antidepressants, antipsychotics, benzos, and psychostimulants. And so the free-floating chemicals are then reabsorbed into the presynaptic neuron. They're reabsorbed into that process right after they've been released. And that helps with neurotransmission and helps you feel better. And helps your mood improve. And normally those chemicals are composed of dopamine, serotonin, norepinephrine. The older drugs, it was like GABA. That was with your MAOIs, but you don't take those anymore. So moving on to your anti-anxiety agents. So the reason that you're going to take these, obviously, is for your anxiety disorders and your anxiety symptoms. That's obvious because they're an anti-anxiety agent. So has anybody ever heard of anti-anxiety agents being used for alcohol withdrawal? Some people yes, some people no. So they're very effective at decreasing the medical discomfort, side effects of alcohol withdrawal, because alcohol withdrawal is very uncomfortable for patients. And you'll see that as you go through substance abuse units in your clinical. They can go into something called delirium tremens, and they become out of their mind, crazy, and it's very sad to see, and they get very sick. People can also seize when they're coming off of alcohol, and so this helps increase the seizure threshold and keep them from having seizures. So it helps with skeletal muscle spasms, convulsive disorders, status epilepticus, and preoperative sedation. So people love having surgery because they get to have some Ativan or something. But the exception of this is Buspar or buspirone. It doesn't have any dependency or tolerance issues. However, most psychiatrists don't like it. It's long-acting, like you have to build up a reservoir of it, and it can't be used on a PRN basis. So you have to be very compliant with the medication in order for it to work. Now, why do you think that this is a medication that people are very hesitant to prescribe? What's the downside of anti-anxiety agents? yeah, you can develop a dependence on them very, very quickly and very easily. So they're used a lot of times as PRN medications to calm a patient down, but however, they develop dependency issues very, very quickly. And you can have a very high tolerance for them, so you need more and more to get them to work and have the same effectiveness. Then they work they work more if you take them with other medications. So if you combine them with other narcotics, especially opiates, then you get this increased effect. And so people a lot of times start combining medications, and that's where you get into overdose territory. That's when people get really sick and can die. You have to be careful about herbal depressants, so especially if they're smoking cannabis. It's just like St. John's wort and depression. You can really affect your medications if you're taking all these over-the-counter supplements, or if you're smoking weed. Which a lot of people now are doing that. And I wasn't aware of this, and I found it interesting that you can have decreased effects of cigarette smoking and caffeine. Now, a lot of your hospitals don't give caffeine anymore in the facility, but what if all your hospitals do? They give these patients what? Nicotine patches. And I wasn't aware that there was contraindications with nicotine. I found that pretty interesting. I'm not going to test you and relate the nursing diagnoses really heavily to pharmacology. Now, there are some where there's like safety. There might be some kind of question related to safety in a nursing diagnosis. But we go through the nursing process in this first section, and obviously that would be more applicable than the pharmacology aspect. So you've got your risk for injury for seizures, and then obviously some risk for activity intolerance for sedation. But you see this theme just shows up over and over again. Okay, now safety. You can kind of highlight and red pen this one, and you'll hear Dana say that all the time. That's why I say it, because I listen to her for a whole semester. Highlight red pen, highlight red pen. See, it's you get conditioned in this program. But if you don't know an answer ever on a nursing test, especially in psych, if there's safety as a selection, just pick it. If you don't know the answer, you've got a good chance of getting it right. Because everything's about safety, especially in psychiatric nursing. Safety. Check. Okay, didn't know what you're talking about today. So, the Institute of Medicine and OIG especially, they're always talking about safety in facilities, and there's huge reimbursement tied to safety, and they're always touring facilities. Like Central State, for example, they were worried that OIG was going to ding them on doors because they didn't have doors that had secure hinges that patients could hang something on. So what was their solution? Like a week before OIG came, they just took all the doors off everything. We're like, we're panicked, we don't know what to do, just take the door down. So all the metal doors just came off until they could figure out a hinge that wouldn't cause something to get caught. Well, I guess the patients are going to get out, aren't they? We don't care, just take the doors off. Might get stuck on something. So there's just doors laying around the hospital. What'd they do? They just sit in the doorway. So they just have staff sit in the doorway. That'll keep the patient from getting out. What the hell? Not if I sit in the doorway. That patient sure is. You want out? Go right ahead. I'm gonna hit you in the face. No, you're not. Have right at it. You want my keys? Go for it. But yeah, always pick safety. So the outcome criteria for anti-anxiety agents, the things you want to specifically be looking for. So you want to make sure that the patient is having a reduction in anxiety and they're responding to the medication appropriately. You want to make sure that their seizure threshold is increased and they're not experiencing any signs and symptoms of seizure activity. They haven't had any physical injury, so what would be the biggest example of risk for seizure or for physical activity that you see in the hospital? Obviously falls would be a big one. So you're giving them their medication, they're so sedated and unsedated that they fall and hurt themselves. You don't want to have any fall incidents, that would be a huge one. Or running into something. You still want them to be able to carry out their activities of daily living on their own and participate in groups effectively, not just be sleeping all the time. That they're not confused, they're still able to verbalize things effectively. to talk about the side effects of the medication. They're able to acknowledge that this is hopefully a short-term fix, and they know that there's the possibility for dependency. And that whenever, we're doing this short-term, because if we let you stay on too long, then we abruptly take away the medication, you can experience withdrawal, very, very. So based on what we've talked about, which of the following medications would be appropriate PRN medication for an individual with anxiety symptoms? So we're talking about something for a PRN basis. So you've got buspirone or Buspar, alprazolam, fluoxetine, and sertraline. So fluoxetine, Prozac, and sertraline, Zoloft. Which one would be most appropriate? B. So that's the generic for Xanax. This has some anti-anxiety properties. Buspar is long-acting. And alprazolam, Xanax. Everybody will take a Xanax, so you don't want to use that long-term. Antidepressants. So it was one of the first antidepressants that was used. And it's an MAOI. So what do you know about MAOIs from your med surg classes? And take it with what? Yeah, tyramine. So it's got a lot of food, because all of our psych patients are eating at fine dining restaurants, drinking red wine, aged cheese, and all that stuff. It's a big eating out of a dumpster. So you have to be very aware of lifestyle choices and side effects as related to food and things that you're eating. But they have a lot of other side effects, and so they're not really utilized anymore. I've never seen one in the clinical setting, I don't think. If I have, I've looked over it and not really paid attention, but I've never seen a weird name that I haven't recognized, so I don't think so. So in all honesty, am I likely to ask you anything about MAOIs? No, because I don't think it's clinically applicable. You're not going to see it, so therefore I'm not going to ask you about it. I'm only going to really ask you things that you're clinically going to see a lot. So, and even in medical, you're going to see a lot of antidepressants and antipsychotics because people are crazy. That's just a lot of mine. Everybody has issues. So, SSRIs and SNRIs are the first line treatment for depression. So it says in the name, it's just like what we talked about. Selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors, they allow more of those chemicals to be free floating in the brain so you feel better. So the most recent additions are your atypical antipsychotics and your typical antipsychotics, and they increase the availability of serotonin and dopamine. So two other dopamine's another feel-good chemical. So with your antidepressants, you're looking at major depressive and dysphonic disorder. And we'll get more into the definitions of those, but dysthymia is like you've had a feeling of not being so well, like slightly less than depressed for a period of like 2 years or less. It's a weird definition, but that differentiates major depression from dysthymia. And I'm like, they're just depressed, but it is slightly different. Then they're used off-label for anxiety disorders, bulimia, premenstrual dysphoric disorder, your borderline patients, which are some of your most difficult patients to deal with in the psychiatric setting, obesity and smoking cessation, and alcoholism. We've already talked about the mechanism of action for these drugs. Now these charts, they're scattered throughout the lectures. So I don't expect you to know everything on these charts. So when you're glancing through them, like I said, I'm going to test you over things that are going to be clinically applicable. So what's something that you're going to see in the clinical setting, even if you decide to work in medical? And so what on here is like a high-risk medication? Taking it first glance, warfarin, one of your blood thinners. That would be something you have a very good chance of seeing in a med-surg facility, critical care, the ER, psych. You have to be really aware of that and make sure to administer it closely and carefully. Because it's got increased risk of bleeding. Like with Buspar, we don't even administer that a whole lot in the psych setting because it's not really that effective. But warfarin, okay, that would be something I could ask you about. Obviously alcohol and benzos, that's huge in the psychiatric setting. So that would be something. Not anything huge on this one. Now, your morphine, narcotic pain relievers, hypertension, obviously that's a big one. You can even throw in respirations into that one. So look at things that are clinically significant. Things that have to do with diabetes, obviously. Diabetes is a huge. I just read an article right before I came to class that it was almost 10% of all adults in the United States are now diagnosed with diabetes. The number's still growing. It's been something with ANA. Look at our Australian exchange students, it's like y'all unhealthy. You could go out and eat some bananas. Like people in Australia, healthy. We swim all the time, we surf. It's ridiculous. I lived on the beach, I did the same thing. So, your diagnoses here, obviously risk for suicide, risk for injury. Now, you say risk for suicide, and you're like, well, why is that? Antidepressants are supposed to make you feel better. Now, the FDA has what they call a black box warning on all antidepressants. So why is that? What's that mean? Having a black box warning on the antidepressants.
Suicide.
An increased chance of suicide. Now, why is that?
Increases your activity or your, what's the word I'm looking for?
You start feeling better.
Yeah.
So especially in children and adolescents, after starting a medication, after the initiation of treatment, within that first few weeks, because we know that with your antipsychotics, your antidepressants, your anti-anxiety agents, takes a few weeks, 3 to 6 weeks, before you start really feeling the maximum impact of these medications. But within those first few initial weeks, you start to regain clarity and start to say, oh, I feel better. Life still sucks for me. I have no assets, or I don't have a house and stuff. This isn't any good. And so they carry out their plan that they had. So you always have to be aware of it and be taking into consideration, are they at any risk for suicide, and are they doing any odd behaviors, giving away possessions, talking about it, verbalizing. So you have to be very cognizant of what's going on with the patient. Again, when you look at safety, there's that word again. So people have to take into consideration what's a manageable side effect versus one that's not. So some things like dry mouth, sedation, mild sedation obviously, some nausea, some gastrointestinal issues, okay, that's all right. We can deal with that. You educate your patient. I can deal with that, okay, just drink a little more water. Be careful when I get up. Now, you've got this middle-aged man. He's feeling better. He's all of a sudden, been depressed for a long time. He started him on Prozac or something. Got some pet in his step. Him and his wife have been having a rough time. He's all of a sudden starting to know the romance now. I feel great. What the hell? I'm not working anymore. You didn't tell me about that. So now you think he's gonna be med compliant anymore, because now he's having sexual dysfunction and impotence and all that stuff. It's a huge side effect, and then your antidepressants. Well, he wasn't aware of that was going to happen, so now he's real mad at you as the nurse and the doctor, because you didn't tell him about all that kind of stuff. Now you had this crazy little adolescent. You gave her some Seroquel to get her under control, an antipsychotic, and her behavior got so good, she started making good grades in school, and then boom, she gained 40 pounds. Now she's coming after you with a stapler because she got fat. She's a high schooler. You're like, you didn't tell me that I was going to blow up like a balloon when you gave me this medication. So you got to educate your patients and do it, very honestly, and make sure they're aware of all the side effects, because sometimes they can react kind of overtly if they don't know what's going on. Okay, so moving on to our mood stabilizing agents. So this one has a lot of juicy information in it. So has anyone ever heard of lithium before? Medication lithium, okay. Did she teach you about this in farm? Yeah, okay. bipolar. So what do you guys know about the diagnosis of bipolar disorder? What's it characterized by, classified, like the symptoms?
Manic depressive, or like really high ups and.
Yeah, very high ups and then, extreme lows. So with the manic phase, what is a manic phase, a true manic phase? What does it look like?
Restlessness.
Yeah, having extreme restlessness. What else?
Racing thoughts,
Yeah, very impulsive, racing thoughts.
feel like they're on top of the world.
Mm-hmm.
Not sleeping, functioning properly.
Yeah, staying awake for days on end and being very, very impulsive and doing very odd things with money and belongings. Some people think it's just like, oh, they went on a little spending spree and they're very hyper. Like a true manic phase is very odd and the patients are very difficult to deal with. We have one at the hospital right now. And she's old. She's gonna be with us forever. She looks a lot older than she is. She's only 55, but she looks like 85. She drank a lot, but she's bipolar and had extreme mania and then extreme depression. But she would do things like take $100 bills, like empty their savings account when she was in a manic phase, and just go up and down her street with her neighbors and just throw $100 bills in the air and stay up for like 2 weeks and just hand out $100 bills to her neighbors. I wish I lived on the street. But like that's mania, like doing really ridiculous stuff. A lot of times what people think of as bipolar and then mania is hypomania. A lot of times treating bipolar with hypomanic states is very difficult because they have the downs, they have depression, but then they have this hypomanic state where it's just below mania. And so what do patients feel like? They feel great. They like it. They get really disappointed when they fall out of this hypomanic state because they're actually really productive. They're good. They stay awake. They do get some sleep, and they get a lot accomplished. And so they like this period of being in a hypomanic state. It's like almost like Adderall all the time. And so you start giving them treatment, and then they're normal, and then they're like, I don't like this. Like I'm tired. And I'm like, yeah, you're normal. Like that. Enjoy it like the rest of us. So yeah, you can't feel good all the time. You come back down to earth. So they're very resistant to treatment. So lithium was one of the first medications that was introduced, but the problem is it has a very narrow
Therapeutic.
Yeah, very narrow therapeutic index. And so you have to monitor to keep them at the corrective treatment range. And it's a salt. And so anything that affects serum sodium levels in the body is going to mess with that therapeutic range. And so other medications, diuretics, what you eat, take all those things into consideration. Alcohol is especially important because it does what? It diureses the body, it affects metabolism. So all of these diagnoses, same things that we've seen, there's a lot of risk for injury. So here's your therapeutic ranges for acute mania and your maintenance dosage. So both of those you need to be familiar with, and then pay very close attention to the question, whether it's referring to acute mania or your maintenance dosage range. And just don't misread it and pick the wrong one. Or it might even be something like fill in the blank. So again, you want to make sure that the patient is taking nutritional considerations and keeping that in mind, and then watching weight gain. Have to make sure that you're monitoring that and the patient is aware of that side effect. Another medication that is used for, another couple medications that are used for mood stabilizing agents is Depakote or Depakine. Those are both anticonvulsants. And then topiramate or Topamax. Now the problem with your anticonvulsants is, of course, you have to be looking for any type of seizure activity that might go on. And Topamate and Topiramax has gotten kind of a bad rap because initially people really like it, because it does what? Is anyone familiar with topiramate or Topamax? Helps you lose massive amounts of weight. People love it. It was originally used as a headache preventative, and then they said, oh, in increased dosages, it helps you stabilize mood. It's an off-label product. But then people experience a lot of thought blocking. Some people even said they forget how to read. They can't read anymore, retain any knowledge. So, and this kind of started getting a bad rap. You have to be titrated up on the medication. You have to be titrated down on the medication. You experience extreme withdrawal. So, some people say they don't experience any of that. So, it's to each his own. But some people say it's extremely successful. You do see that a lot in the clinical setting. So moving on to your antipsychotics, which is kind of the bread and butter of psychiatric nursing. So amazingly, this is what people are so resistant to taking. When you offer an anti-anxiety medication, so benzodiazepine, everybody's compliant with taking their Ativan. You have no problem getting them to take that. If you ask them to take their Seroquel, nobody wants to take that. They'll take their Ativan. They don't want to take their Seroquel. It's amazing how that works. But these are used to treat hallucinations and delusions. These are some of your most serious symptoms that you're going to see. The big side effect is your EPS, extrapyramidal symptoms, which you're aware of. So these include the acute dystonias, Parkinson-like symptoms, and your tardive dyskinesia. Your tardive dyskinesia is like the tongue sticks out, it makes really weird movements, the face can make really weird movements, and twisting movements, the patient gets up and down, wrings their hands. So it's very, whenever you see it, it stands out. So what you want to do is you want to mitigate those side effects. And to do that, you give these medications. Because what happens is that those symptoms develop because you've given such high doses of antipsychotics. Normally the generation 1 antipsychotics like Haldol, H-A-L-D-O-L, or Thorazine. And so if a patient's receiving such high doses of those medications, what's that probably mean about the patient's behavior? It's not very good. Probably bad. They've probably been acting out and they're extremely aggressive. So, do we want to decrease the dosage of the medication or discontinue it? Legally, if they're that bad. So we'd like to keep the medication on board because they need it, but we don't obviously want them to have this adverse effect. So we try giving them benztropine, cogentin, Benadryl, diphenhydramine. Those are the generics and trade names of each of those medications. So we'll try Benadryl or cogentin and try and pull them out of the EPS. If that doesn't work after a couple doses of that, then we'll start looking at pulling medications off or decreasing the dosage. We might have to change the patient to a second generation antipsychotic like Geodon or Seroquel. Now Geodon is actually injectable. Zyprexa is injectable. So then we might change them to one of those so we can give PRN medications through IM. Sometimes they'll build up, it's almost like they build up a toxicity in their system, and it's very difficult to pull these patients out. And sometimes it's just troubling because they'll develop symptoms immediately, like all of a sudden, and then they just won't go away. And you don't understand why, even after you pull them off their medication. Especially with the children. Sometimes they'll keep them with the symptoms for a long time. So that's very troubling. So we know that your antipsychotics are used for schizophrenia and other psychotic disorders. They help treat bipolar disorder, and then you can use them for things like Tourette's and odd tics that the patient has. I'm not going to test you over, the mechanism of action of these medications, but this just gives you an idea. Again, you're dealing with the dopamine, in the brain, and how it affects the synapses. And again, you're looking at dopamine here, you're looking at some of the cholinergic action. You don't have to worry about the acid overdose. So with the contraindications here, the problem is these medications are highly synthesized and metabolized in the liver and kidneys. And so people that have a lot of comorbidities, you've got to really pay attention to their hepatic enzymes and their kidney enzymes, or kidney functioning. And then look at, also with your antipsychotic medications, when you're combining them, they affect heart function and cardiac function on a significant level, especially when you're combining first generation and second generation antipsychotics, which is kind of a no-no. They produce, on this second slide, they produce prolonged QT intervals, and so it can really affect heart function, cardiac function. And so as you can see on both of these slides, I mean, anybody with medical comorbidities is going to be at risk to have sensitivity to these medications. The problem is, are psychiatric patients very compliant with any type of medical direction that you're giving them? No. And so, like you see on this, anything that increases pressure, like glaucoma, any types of blood dyscrasias that exist, any type of diabetes, I mean, that's in here. Well, of course they can't manage their overall well-being, you know, even just generally taking care of themselves. You think they're going to be very compliant with their diet, insulin? Obviously not. So of course everything's uncontrolled. You know, you just have to monitor it the best you can, and you're still giving these medications, but obviously there's going to be a risk with it. Again, with these charts, the drugs that prolong QT intervals, that's extremely important. The two that are most problematic are Thorazine, for you to take note of, Thorazine and Geodon. That can cause a deadly arrhythmia, can actually stop the heart. And that's something that people still aren't really aware of. They should be, but they're not. I actually gave Thorazine and Geodon together several times until a more seasoned nurse that worked with me said, you're not supposed to do that. And so I called pharmacy, and sure enough, you're not supposed to do it. However, pharmacy and the doctor wrote many orders to given it, and pharmacy had loaded it in the Pyxis for me several times. Then when I called the doctor back, he said, no, fine, you're not supposed to do that. So sometimes they're not, they forget to. Is everyone okay on the spelling of that? Can you spell it?
Yes, spell Geodon.
Geodon, Geodon. Thorazine, Thorazine. So with your psychotic patients, obviously there's a risk for other directed violence. And I joke about like letting patients out, like, no, I'm not going to get hit. You can't let patients out, unfortunately. It's your responsibility to keep them there. We had a patient admitted last night that he was released from jail on the 15th. My partner works down at LMDC. He's a platoon sergeant there. He wasn't aware of the patient asked, did you have anybody crazy admitted or discharged on the, released on the 15th? He was really tall, African American, like huge, like almost 7 foot tall. I don't remember, I don't think so. And we had like 10, U of L had to have 10 security guards hold him down yesterday to manage him. Then he came to Central last night, and it was me, 2 female techs, female security guard, like an ancient, old security guard that was like 80, and another female supervisor. And I was like, we are not rolling that deep. Like, this is not a good situation. But he was strapped to a stretcher and got out. We were doing his admission, and his hand was all wrapped up. And I said, well, what brings you in? And he was like, everybody in Louisville's effing lame. And I was like, oh, well, I said, we're here to help you and all that kind of stuff. I said, well, how did you, then we were doing his belongings. Now this is what's crazy. This is the kind of stuff that will scare you. They were doing his belongings and I was looking. They get to this last little bag that he had, little black bag. They're undoing it. Inside of it, they pull out one Magnum condom. And I'm like, it's safe, it's good. But then it's followed by 2 or 3 pairs of black latex gloves, a pair of black leather gloves, a ski mask, a little bottle of some kind of cleaner, and duct tape. What's that sound like to you? Some unsolved mysteries is what it sounds like. Heard of those supervisors, he's got a rape kit in his bag, and I was like, where are you from? And he said, New York. I'm like, he is a serial killer just walking up and down the coast. That's what he is, serial rapist. I said, well, how did you end up in Kentucky? And he said, I was traveling from New York and tripped over Indiana and landed in this shitty ass state. And I was like, sweet. I said, well, next time, can you land in West Virginia? Not come to my city? And I said, what happened to your hand? And I unwrapped it and looked at it. It was all swollen. I said, how'd your hand get swollen? He was like, punching MFers in the face. And I was like, can you not punch me in the face? He's like, no, I won't punch you. I was like, well, don't punch anybody in the face while you're here. And he was like, all right. I was like, okay, well, that's good. No, that's all. This is horrible. But yeah, I was like, he has got a rape kit in his bag. He was like, how did it? And I was like, why did the police take this from him? Why did they discharge him with it? Like they were going through and they were like, that's not odd. We should Google and see if anybody's missing. Like 14 women got missing between New York and Indiana. Well, I guess he tripped over Indiana, so he didn't go there. But ridiculous. So safety issues that you want to be aware of. You know, educating the patients that are truly psychotic are obviously very difficult. Educating them on anything, you know, that's why I chose to do my doctorate over educating psychiatric patients about HIV and AIDS. I mean, a lot of them are very, well, he had a condom, so that's good. But a lot of them don't. They're extremely promiscuous and, you know, they spread a lot of diseases between each other and then don't treat those diseases. And so, you know, viral loads for Hep C and HIV and stuff are out of control. Clozaril, one of the medications, causes agranulocytosis. So you want to monitor white blood cell counts with those patients. We talked about EPS. There can be a huge range of hormonal side effects. Everybody's seen those commercials about like the Becker Law Office, you know, if you develop breasts and you're a male, call if you've been on Risperdal. You know, so some of the medications can cause gynecomastia in males and stuff like that. So when you're looking at pharmacological treatments, this came up, and I've yet to look it up, but I'm not familiar with that medication. I haven't ever seen it used in a clinical setting, so it must just be completing clinical trials. For your outcome criteria, obviously you want the patients to have decrease in their psychotic behavior, being compliant with medication, verbalizing some of the side effects of the medication, and showing medication compliance, and having no increased sedation or injury while being on the medication. Your sedative hypnotics aren't used nearly as much as they have been in the past. They help treat anxiety, insomnia, preoperative sedatives. They're used in preoperative conditions, and alcohol withdrawal. They're still used in some withdrawal protocols instead of benzos because they have less affinity to for addictive tendencies and dependence. So Rosarum, it's a sleeping medication. So it depresses the CNS, all of these medications do. But it's one of the ones that's not a controlled substance. So the contraindications with these medications is that, again, you can see a trend that's developing here. All of them affect hepatic, cardiac, and renal function. And this medication, does it look familiar to anybody? Chloral hydrate? No, because I know some of you guys are a little bit older. You might be around my age. So chloral hydrate was the medication that killed Anna Nicole Smith, if anyone remembers that. she used that, and it's a very potent sleeping medication. It's like Michael Jackson level potent. So she, of course, thought it was a great idea to drink while using that and then take a whole bunch of other pain medications because I guess she was really tired and just couldn't get to sleep. And it ended up killing her. So she couldn't wake up. Well, one class, in the first day that I lectured, of course, students always pick out your weakness. And she was like, what's this mean? And I was like, and I'm not a geneticist, never claimed to be one, but I didn't know what that was, and I had to admit it that I didn't know what it was. Some things you can't think. So I was like, I don't know, but I looked it up, and it is a recessive, autosomal recessive trait that affects the heme group of oxygen binding. Yeah, that's why I didn't know what it was. Smart, I'm not that smart. Affects the oxygen binding heme groups of the red blood cells, and you're not able to transport oxygen very well in your body. And it messes up a lot of organ systems. So you shouldn't use this sleeping medication if you have that autosomal recessive disease. And especially take alcohol, drink alcohol, and take a bunch of pain pills, or you could have a real messed up situation like Anna Nicole Smith did. There you go. Any other questions about that? So all of these medications, you know what your barbiturates and your benzodiazepines are. The rest of these are sleeping medications. Of course, you want to look, if you come off an abrupt withdrawal of these medications, you can't have insomnia. But you want to watch out for confusion and activity intolerance and injury. Again, with your safety issues with these medications, you have to watch out for suicidal ideation, which that's another theme that develops throughout all these lectures. You guys get out at 5? 5:20? Okay. So then moving on to your central nervous system stimulants and those types of agents. So of course you know about your ADHD medications. Then some of your amphetamines are also used for narcolepsy and obesity. However, your physicians will be hard pressed to prescribe these medications for those types of diagnoses. And why do you guys think that is? Yeah, they have a very high potential for abuse, and now they're so tightly controlled. The doctors have to run Caspers on everybody, and the doctors are very closely watched when they prescribe these medications for certain diagnoses. And so it would be very difficult to get medications for a diagnosis like that. So bupropion, has anyone ever heard of this medication? You know what generic that's generic for? Wellbutrin. So Wellbutrin actually is a branch of what used to be Zyban. Zyban was originally developed as a smoking cessation aid. So a lot of housewives one day said, I want to quit smoking. And so this medication Zyban came about. And so they started taking it, and they said, wow, I quit smoking. I'm losing weight. I'm super productive. This is amazing. And so the manufacturers looked at this and said, we're going to market it under a new name, extend the patent again, and make more money. And they capped the dosage at 600 milligrams. And then people said, well, 600 milligram works, and you lose weight. I'm going to take 9, because they come in 300 milligram tablets, and I'll lose even more weight, and I'll be even more productive and feel even better. And then what happened is people started having seizures all over the place when they took close to 1,000 milligrams. Because this medication lowers your seizure threshold a whole lot. You're almost guaranteed to have a seizure when you get up around 1,000 milligrams or 1,100 milligrams. Especially kids who were popping it like Tic Tacs who thought it was Adderall. So they lowered the dosage to 450 milligrams as the max. And it became generic, and it's actually very effective as an adjunct or alternative to amphetamines. And it helps ADHD in children, and it's a great kind of atypical depression medication. And it can help with weight control and all that kind of stuff. I'm a big fan of Wellbutrin. I like it when our patients get it. I feel like it's very effective. treat hypertension. Troponidine will be on your opiate withdrawal scale, because a lot of times you'll have hypertension that'll come into play, increase blood pressure when you withdraw from opiates, so that's included on your opiate withdrawal scale. So CNS stimulants, they directly increase the level of your neurotransmitters. This is Strattera, which is a long-acting form of CNS. It's a once-a-day stimulant that you can take and acts throughout the whole day. See, this is why I like Wellbutrin so much. Look at all the things that it does. Blocks the neuronal uptake of serotonin, norepinephrine, and dopamine. All three. One pill. Drink more water. That's why it was so good. And you don't smoke. So you have to, again, watch out for cardiac side effects with these medications. And you have to be very aware of the history of drug abuse. So why is that? Because all these medications have a very high propensity for dependency. So if anybody has that type of history, you obviously want to watch out for it, because again, they can be used. And you also need to look outside the sphere of just the individual, because who else might have a very high potential to utilize these drugs for dependency and their own use, especially in children. The parents. And that's even been shown in documentaries and on the news. The parents will take their own kids, especially younger kids. Their kids will still be acting a fool at school. They've been diagnosed with ADHD, and they're like, what's going on? Aren't they getting medication? And they're not, because their moms are taking all of it, or their dads, or their sister, or brother, or whatever. So this is Focalin. That's the methyl whatever. Focalin. It's been a long day. I can't pronounce that right now. Strattera, Wellbutrin, and then your alpha agonist. So again, you have to watch out for, these are all things to watch out for, basically side effects whenever you're taking a stimulant. You know, it decreases appetite, keeps people awake, which can also affect your health. Suicidal ideation increases. People could be injured because of lack of sleep. You can become overstimulated, have dry mouth, seizures, mainly because of the decreased seizure threshold because of bupropion. Strattera can cause liver damage if they're taking too much, and it's long acting, so they're not going to get that high that they normally get from taking something like Adderall. So a child's taking guanfacine for ADHD. Which of the following would be part of the client education associated with administration of this medication? Don't take foods that contain tyramine. So what's that one talking about? Mayo eyes. Always use sunblock when spending time outdoors. Talking more about some type of integumentary issue, or maybe like a minocycline or doxycycline, more of an antibiotic that causes sun sensitivity. Report for blood tests once a month. What's that one talking about? More of your antipsychotics that cause your agranulocytosis. So your Clozaril. And then don't discontinue the medication abruptly. So which one? D. So clients taking alpha agonists should not discontinue therapy abruptly. To do so may result in symptoms of nervousness, agitation, headache, and tremor, and a rapid rise in blood pressure. So basically withdrawal symptoms. Serious withdrawal symptoms. And it should be titrated down under the supervision of a physician. So they slowly increase the dosage of these medications, and you have to do the same when you're taking patients off these medications. Okay, so we get out at 5:20, right? So take a break until 5 till, and then we'll quickly go over ethics.